Bismillah ar-Rahman ar-Rahim. I'm Dr. Ghada Ashmawy, Professor of Neurology, Faculty of Medicine, Alexandria University. Today our lecture is MS or multiple sclerosis. It is one of the demyelinating disease. I hope at the end of this lecture we can define the multiple sclerosis, pathogenesis and pathophysiology, risk factors, clinical picture and management. We must first differentiate between two terms here, demyelination and dysmyelination. Demyelinating disorder means there is destruction of the normal myelin, while dysmyelination means there is abnormality from the start in the myelin. Here there is affection of myelinogenesis, while here there is intact, healthy myelin destroyed by toxic or chemicals or autoimmune substance. This is the epidemiology of MS. MS is a global disease affecting mainly 2.8 million people worldwide, and in Egypt it affecting about 51 to 100 in 100 people. This is the cerebral cortex, mainly formed of the core of the neuron, and this is represented the gray matter. And this is the axon covered by the myelin, and this is represent the white matter. Our disease affecting mainly the white matter. There is destruction of the normal myelin, so there is affection of the white matter. So it is disease of white matter, not a disease of gray matter. The definition of MS, multiple sclerosis, is mainly autoimmune disease, inflammatory, demyelinating, neurodegenerative disease, affecting mainly the young adult, females mainly in between 20 to 40 years old. What are the characteristics of the MS? To define MS, for an example, if we have a patient, female patient, 24 years old, presented with right hemiplegia, then this resolve it completely and the patient regaining to the baseline. After 1 month, the patient may be represented by loss of vision, and then after 2 weeks, the patient returns to the normal. 1 month later, or 2 months later, there is affection in form of quadriplegia and ataxia. But the first attack in form of hemiplegia, the second attack in form of optic neuritis, the fourth attack in form of quadriparesis and cerebellar manifestation. What is the significance of this? There is a dissemination in time, first attack, second attack, the third attack, and there is a dissemination in space. Firstly, affecting the pyramidal tract. Secondly, affecting the optic nerve. The third part affecting the pyramidal as well as the cerebellum. This means there is affection in dissemination in time and dissemination in space. Dissemination to diagnose MS, at least we need 2 attacks in between at least 1 month. But to diagnose MS, we need dissemination in time and dissemination in space, 2 attacks at least in between at least 1 month. The key principle for diagnosis MS, dissemination in time, meaning suggestion of damage in more than one place, maybe optic nerve, maybe pyramidal, cerebellum, or affection of the sensory manifestation. Dissemination in time means suggestion that there is suggestion that damage has occurred more than 1 month. This is called relapsing remitting MS. This is relapse reflecting demyelination, while the remission reflecting remyelination. This is type called relapsing remitting. If there is progressive of the symptom, relapsing remitting type transform it to secondary progressive type. What happens? We don't know the pathogenesis or pathophysiology, how occurs. Suppose this is the patient for the MS. It exposed to certain environmental factors or may have genetic susceptibility to develop MS. The most important environmental factors is the virus, epstein, Epstein-Barr virus. When the patient exposed to this virus, this is affecting the immunological system to response in form of release of T cells and release of the B cells. So it is an autoimmune disease. The response of the body, secretions of T and B cells. What happened when there is secretion of T and B? There will be inflammation, demyelination, attacking the oligodendrocyte, which is forming the myelin, leading to reactive grayosis and neuroaxonal degeneration. This is a normal myelin, and this is normal axon. When there is attacking of these T and B cells, there is destruction of the myelin with relatively preservation of the axon. What happens if there is destruction of this myelin? Why the myelin is destructed? Although there is a virus, why is this T and B cells not directed to the Epstein-Barr virus? The virus have a surface antigen may mimicry the sequence of antigen here in the myelin. Cross-reaction will happen. Instead of directing to Epstein-Barr virus, it will be directed to the myelin. So that is an autoimmune disease. The lymphocyte release cytokines, lymphokines, while the B cells will secrete antibody. Antibody and the lymphokine cytokines directed to the myelin, leading to destruction, leading to inflammation, leading to formation of neuroaxonal degeneration. With time, it's called scars. So the name of the multiple sclerosis is multiple scars. These scars appear on the MRI in form of MS plaques, accumulation of demyelination lesions that occur in the white, not in the gray matter, mainly in the brain and mainly in the spinal cord. So it is disease of white matter affecting central nervous system, mainly affecting the brain and the spinal cord. As we just said, it is an immune-mediated disease leading to release of T and B cells. This is not enough. This is influenced by the presence of genetic susceptibility and the presence of environmental factor. Genetic susceptibility, the patient has HLA antigen chromosomal 6, including DRB1, have 3 to 4 times risk for development of MS. The environmental factors, which is modifiable factors like smoking, low vitamin D, Epstein virus, as we just explained, obesity, and gut microbiome. What about the other risk factors? This disease affecting mainly females in the age between 20 to 40 years. Before 20, it is difficult to diagnose MS. After 40 and 60 or 70, it is difficult to diagnose MS. The onset here between 20 to 40 years. It affecting more the white people, affecting more the woman. We are asking about the effect of pregnancy. The pregnancy as well, it is not alter the risk of developing MS. While postpartum period, the first 3 months, there is increase for development of MS. Now we are asking a question. The first question is, which age group in MS most likely to strike? Children under 12, teens, adult age between 20 to 40, adult age 65 years old. What is the answer? We are going to talk about the subtypes of MS. We have 4 types: relapsing remitting types, which represent 80% of the cases of MS, the secondary progressive types, which represent about 65% from the relapsing remitting type, and 10% for the primary progressive type, and finally progressive relapsing type. This is the type of relapsing remitting type. This is relapse, which represent the demyelination, and followed by remission, which representing the remyelination. After a while, there is relapse followed by demyelination, remyelination. So we have multiple relapse followed by multiple remission. This is called relapsing remitting type. After time, there is a sequelae of the patient, like some residual hemiplegia, some residual ataxia, some residual blurring of vision. So it transformed the relapsing remitting type into the secondary progressive type. So there is 65% from this type will be secondary progressive type, which may ending the patient to be on the wheelchair. The sickle may be reaching the patient to be on the wheelchair. This is malignant type. It is primary progressive type. From the start, it is progressive, and it is most malignant type. This is more details about the relapsing remitting types. The relapse typically showed an acute and subacute onset. Acute and subacute onset worsen with duration at least 24 hours. Over days or weeks, reach a peak severity 2 to 3 weeks. It may take 2 to 3 weeks. The remission variable degree ranging from minimal resolution to a complete recovery 2 to 4 weeks after reading maximum deficit. Remission and relapse may be transformed to secondary progressive. What about the clinical picture? The clinical presentation is heterogeneous, multifocal, depending on the location of the demyelination. When there is destruction of the myelin, we're losing the conduction velocity. So there is no function of these tracts. If affecting the optic nerve, there will be affection of the vision. If affecting the pyramidal tract, there will be affection in form of motor manifestation. If affecting the sensory tract, it will be in form of sensory manifestation. Single relapse may affecting optic with cerebellum. The other attack may affecting pyramidal with sensory. So it is a heterogeneous, multifocal, depending on the location of the demyelination. The first is optic neuritis. This is the initial symptom of MS of optic neuritis. There is affection, demyelination of the optic nerve. So the presentation in 50% of the cases represented as visual loss or blurring of vision. The very characteristic thing here is there is loss or blurring of vision in single eye. In single attack, there is affection in one eye. It's not occurring simultaneously on both eyes. This is very characteristic for demonstration of optic neuritis as demyelination in MS. If there is affection of the sensory system in form of posterior column or spinothalamic tract, there will be sensory manifestation, which may occur in 55% of the cases. It may be presented as numbness. Numbness means deadness. The patient cannot feel. This is loss of sensation. Or tingling sensation, which means paresthesia. Or abnormal sensation, like burning sensation, in form of dysesthesia. Or increase in sensation, which is called hyperesthesia. There may be loss also for the posterior column in form of impairment vibration of joint sensation and reduced pain and light touch perception if there is a spinothalamic affection. This symptom temporarily worsen with exposure to heat. If the patient drink a cup of coffee, there will be increase in sensory manifestation and blurring of vision. If taking a hot bath, there is increase in body temperature, so there is increase in the symptom of sensory and eye manifestation. This manifestation resolve when the body temperature cools to the normal or after a period of rest. This is called Otoff's phenomenon. What about if there is affection of the pyramidal system? If the lesion here affecting the pyramidal system, either here in the white matter or in the spinal cord. What about the manifestation? The presentation may be hemiplegia or quadriplegia or paraplegia. And the motor manifestation characterized by pyramidal signs in form of Babinski sign, as shown here. This is Babinski sign, extensor plantar, or in form of clonus. There is rapid repetitive movement when we make the ankle like this, or there is a hyperreflexia ankle or knee. Also, there is affection of the cerebellum. Here, there may be affection in the cerebellum in form of dysmetria, like this. He cannot reach the target, hypometria or hypermetria, or there is action tremor, like this, or there is dysdiadochokinesia. He cannot perform a rapid alternating movement of the hand. So this is dysmetria. He cannot reach the goal. Or action tremor, accentuation of the tremor with action. Or there is a dysdiadochokinesia. He cannot perform rapid alternating movement. Also, there is a visceral complaint in form of urinary urgency, frequency, urge incontinence, even constipation, and sexual dysfunction. The brainstem may be affected also. All they are tract axon covered by myelin, so may be affecting all by demyelination. If it's affecting the brainstem, the presentation may be vertigo, affection of trigeminal nerve. Here the affection is bilateral. When we are talking about the optic nerve, single attack, we have one eye in single attack. Here, the opposite. The trigeminal may be affected bilateral. Also, there is affection of the bulbar complaint in form of dysphagia, dysarthria, regurgitational fluid from the nose, which is called bulbar complaint. And there is what is called internuclear ophthalmoplegia. If there is patches like this affecting the brain bilateral, what are the presentation of the patient? If it is unilateral, the presentation will be hemiplegia. If it is bilateral, the presentation will be quadriplegia. Why it is quadriplegia? There is affection of the pyramidal system on both sides. So the presentation will be quadriplegia. If the tract affecting the corticobulbar as well as the corticospinal, there will be affection in form of bulbar complaint, which is called dysphagia, dysarthria, regurgitation fluid from the nose. If we have quadriplegia, bulbar complaint, we have also visceral complaint. The quadriplegia represent bilateral affection of corticospinal. The bulbar complaint, affection of the brain, bilateral corticobulbar. The visceral complaint, when there is affection of pyramidal bilateral, there will be visceral complaint in form of incontinence or urgency. Also, there is emotional incontinence. Finally, we have jaw reflex exaggerated. So we have quadriplegia, bulbar complaint, visceral complaint, emotional incontinence occurring due bilateral affection also of the brain, and finally the jaw reflex exaggerated. Jaw reflex will be exaggerated. This is called pseudo-bulbar complaint occurring in MS bilateral affection. Here we have pseudo-bulbar palsy in form of quadriplegia, bulbar, visceral, emotional incontinence, and jaw reflex. We can differentiate between two terms here, pseudo-bulbar and true bulbar. Pseudo-bulbar if the affection of the brain, corticobulbar. If the affection in the brainstem, it is called true bulbar. Pseudo-bulbar occurring in MS, it is pseudo-bulbar, bilateral affection of the brain, while the true, it is affection of the brainstem at the level of the pons and medulla. To differentiate, here there is a jaw reflex exaggerated and the gag reflex exaggerated. While in true, there is loss of jaw reflex and the gag reflex. So the jaw reflex is absent and gag reflex is absent. What about the internuclear ophthalmoplegia? This is a normal eye. We have two conjugate eye movement, lateral movement and or horizontal movement and vertical movement. This is the conjugate eye movement lateral, the lateral recti acting laterally, followed by the medial recti. This is normal. What happened in MS? What about the internuclear ophthalmoplegia? This is area 8. This is the 6th nuclei. This is the 3rd nuclei. The 6th nuclei is divided actually into two parts. The dark part giving order to the lateral recti on the same side, giving order to acting laterally. While the whitish part crossing the medial longitudinal bundle to the 3rd of the other eye to giving order to the medial recti to follow the lateral recti. This is the action of the conjugate eye movement horizontal. Bundle, medial longitudinal bundle means axon covered with myelin. So it is common site for affection of the MS plaques. When there is cutting of this pathway, there is order giving to the lateral recti, and the medial recti does not follow the lateral recti. It will be like this. Lateral recti acting, and the impulse from the lateral recti does not reach the 3rd of the other side. So the medial recti does not act. This does not mean that the medial recti is paralyzed. While I'm going to ask the patient to do convergence, there is convergence of the medial recti bilateral. We are going to see it now. The lateral recti acts. The medial recti does not follow the lateral recti. This is called internuclear ophthalmoplegia. This does not mean that there is loss or paralysis of the medial recti, because there is convergence of the eye of the both medial recti. Also, this patient suffering from fatigue in this age, 20 to 40 years, the age of marriage, the age of work, the age of studying, the patient overall 75% suffering from fatigue. Also, after multiple attacks, multiple relapse, there is affection of the cortex secondary to the white matter affection, leading to what is called cognitive disorder. Cognition in memory, cognition, difficulty in concentration, difficulty in memory, maybe also behavioral manifestation. There is also what is called the paroxysmal symptom. This symptom typically brief, 2 to 2 minutes, recur frequently, occasionally dozens times per day. It may be in form of tonic spasm, many times per day, or maybe in form of trigeminal neuralgia. As we just said, it is bilateral affection pain of the face. And also there may be a Lermit signs. This is Lermit signs. When we ask the patient to do like this, flexion of the neck, there is electrical sensation or tingling sensation travels down to the spine into the legs. This is called Lermit signs and very characteristic for MS. The second question, which is the most common cranial nerve affected in multiple sclerosis? It is vagus nerve, facial nerve, optic nerve, or olfactory nerve. It is optic nerve. What about the differential diagnosis? We are searching for differential diagnosis that affecting the brain or the spinal cord in multifocal manifestation. As we just said, it is affecting optic, cranial nerve, pyramidal, cerebellum, sensory. So we search for differential diagnosis mimic the MS, like systemic lupus, Behçet disease, acute disseminated encephalomyelitis, and lymphoma. What about the evaluation of this patient? We are following the criteria of 2017 revision of McDonald's criteria. As we said, there is dissemination in time. To diagnose MS, we need at least 2 attacks in between at least 1 month. The second, there is a dissemination in the space affecting more than 1 space. This in the absence of another identifiable explanation. There is no affection in the laboratory investigation as vasculitis, to excluding other manifestation to confirm the MS, MS diagnosis. The next step, we do MRI. We're doing MRI brain as well as spinal cord because it is a central nervous disease affection. The MS plaques looks like this. It is an oval, patches, plaques, whitish in color, perpendicular on the lateral ventricle, just touching the lateral ventricle. This is very characteristic of MS plaques. The common site typically periventricular here, or juxtacortical may be found here, or infratentorial affecting the cerebellum, or in the spinal cord. The whitish color means this patient, if taking contrast, the enhancement lesion of the gadolinium, which is a dye taken by the patient, space the contrast denoting the activity of the disease. So when we are facing this type in whitish color, means there is the activity of the disease. Again, this is patches perpendicular on the lateral ventricle. This is patches on the lateral ventricle, juxtacortical, and spinal one. The second step, we do CSF examination. It is autoimmune disease. There is response of T cells and B cells. So we are found lymphocytic pleocytosis. We are found due to the presence of B cells increased in IgG index, increasing intracecal production of IgG because it is T and B cells mediated, may be found anti-myelin antibody, and the very characteristic is the presence of oligoclonal band, which is subtype of globulin. It is formed like this. This is MS, IgG, oligoclonal band, CSF. The final investigation is the evoked potential. Actually, we ask about the optic nerve. Optic nerve is the most common cranial nerve affecting in MS. So we asking the patient to do visual evoked potential, which in 90% manifested as optic neuritis in form of increase in latency or delayed the appearance of the curve. This is normal. This is a normal curve, and there is a delay of the curve in the MS in form of increase in the latency. What about this treatment? I must treat the patient in the acute phase and expecting second and third and fourth relapses, so I must protect the patient from these relapses. In acute exacerbation, or which is called relapses, I give corticosteroid. The best corticosteroid, we use it intravenous methylprednisolone. It could be given in 1 gram per day. Could be given 3 days. If there is no improvement, I can repeat it 5 days. If there is no improvement, we can increase it to 7 days. I expecting more and more relapse. And I want to prevent the patient to be on the wheelchair. So I will give what is called disease-modifying therapy. I will alter the natural course of the disease. I will reduce the frequency, the severity, preventing the relapsing progressive type to forming the secondary progressive type. I want to prevent this ability. What are the disease-modifying therapy? We give interferon beta 1b, interferon 1 beta 1a, beta 1b giving injection every other day subcutaneous, interferon beta 1a giving Avonex once weekly intramuscular. The recent drugs, I want you to only know the names: natalizumab, teriflunomide, fingolimod, and ocrevus. We can give the patient symptomatic treatment. If there is a spasticity, I give muscle relaxants like baclofen. Fatigue, I give antiviral drugs like amantadine or adamine twice per day. If there is trigeminal neuralgia in form of paroxysmal symptom, I give Tegretol or carbamazepine. This is our reference. We are going to discuss a case, 24 years old, right-handed student female, who was studying late at night on examination. Her examination, as she looked at her textbook, she experienced a numbness, means deadness, sensation of the left foot and her entire left leg. The feeling lasted a week and then slowly went away. She dismissed the complaint and recalling that she had a similar symptoms 6 months ago, and she remembered that 2 years ago her left eye became blurred and her vision went away. In 1 week, her vision returned to the normal. She had not seen the physician for any of these previous symptoms, and she decided to seek medical consultation of the next day. We must answer 2 questions. What is the lesion? And where is the lesion? What is the lesion? I can answer this question from the history. What's wrong with this woman? It is psychic or organic? What is the answer of what is the lesion? We are answering this question from the above history. Actually, we have 3 relapse or 3 attacks. The first one is the optic neuritis in form of blurring of vision or loss of vision occurred 2 years ago. And 6 months ago, she had numbness and had another attack in form of numbness now. So we have 3 attacks. This is called relapsing and remission. To diagnose MS, we need at least 2 attacks in between at least 1 month. This is 2 years. So from the above history, we know that it is a relapsing remitting type course. Where is the lesion? The second question is, where is the lesion? To know where is the lesion, we must do an examination. What are the examination reveals? Reveals brisk reflex, sustained clonus, right ankle Babinski signs, which is signs of pyramidal manifestation. So the localization, or where is the lesion? It is a central lesion affecting the pyramidal affection in form of the signs revealed by the examination. There is a sensory manifestation in form of numbness, and there is affection of the cranial nerve in form of optic neuritis. So we have dissemination in time and dissemination in space. So this is the key for this case. 24 years old, females, actually the MS affecting the age between 20 to 40, affecting more females. There is a multi-system affection in form of numbness, blurring of vision, and pyramidal affection, and there is a dissemination in time. This happened 2 years ago, and the second one 6 months ago, and this is the current complaint. So the most likely diagnosis is multiple sclerosis. The next step, what we are going to do with this patient, the investigation is MRI, brain and spinal cord with contrast, CSF analysis, and visual evoked potential. We are going to test ourselves by 3 questions. This is the first one. I will leave you to read it well, and I highlighted this key to reach the diagnosis finally. طبعا actually it is an MS. The second one is which of the following treatment of multiple sclerosis relapses? And the final one is if the symptom and physical examination suggesting MS, how does healthcare provide to confirm it? This is the last one. Okay, thank you very much for your attention.